There was a fairly broad question that I'll take. What to expect from a doctor for newly diagnosed patients? It's quite a challenge when somebody's newly diagnosed. You're trying to figure out what the heck is this MS thing they're telling me this is? What's a brain MRI scan? Why do I care about a so-called lesion? All sorts of other things, challenging questions about getting treated. But the main thing you should expect when you go to see your provider is you should expect someone to listen to you. That's probably number one on the list. Number two, they should give you the best idea of facts as they exist. And knowing that there's a lot of uncertainty, not just with MS in general, but with a lot of the things we do. We don't necessarily have perfect answers. So you should expect that when you ask a question, they should be able to tell you this is a this is a hardcore fact, or this is something that we don't have as much data about as we might like to have. So honesty, listening, and then trying to remember what's important for you. What I think is important for you may not be what you think is important for you. And so we should listen to what you have to say, but also to the loved ones you bring with you. They will have a perspective that we don't have. They see you at home. So also important to listen to the people that you feel are important in helping you navigate through MS throughout your lifetime. So those would be the big picture things. And then also, the more specific things like, should I use this therapy? Should I use that therapy? Those are important as well. But I think the biggest thing you want is you want a relationship with someone that you can trust and that you know that when they talk to you, they're giving you the best information they can, even if it's limited. Another question then for Dr. Shah. Can you talk about the relationship of MS and pain? Many years ago, it said, if you have pain, you have to look for all the other causes. Clearly, there are causes of pain associated with MS. And what's the relationship of pain, especially chronic pain, to MS?
There's lots of relationships between MS and pain, but I think none of them are quite as straightforward as we'd like them to be. So the most common types of pains that we could say could be attributable to MS, but again, probably need good evaluation between your neurologist and maybe some other testing, would be something we consider neuropathic pain or nerve pain that usually shows up as painful pins and needles, or a sense of burning or shooting pain are probably the most common things we think about when we think about MS-related pain. Now, some of those might be in extremities. Other types of pain that we hear about is something called trigeminal neuralgia, which is a shooting pain that happens in the face that often gets mistaken for a dental infection. Other types of pain syndromes that we think about related to MS might have a more indirect relationship. So, for example, if I have someone that walks abnormally because of weakness or balance issues or something like that, and they're telling me they have low back pain or hip pain or something like that, that's indirectly related to the MS as a manifestation of how they're walking.
Perfect. We have some more COVID-related questions for Dr. Alvarez. Amplifying what Dr. Schreiner talked about before, she sort of gave her sort of view of, what it means to be immunocompromised and have risks with regard to COVID. This is a very specific question, but if you could talk about your view of this, as Terry did, because it might be slightly different, but this was a very specific question. I'm going on a cruise on May 23rd, 23. When should I get the new booster? And what should I do in relationship to wearing a mask and eating dinner with others and other things like that when you're in a confined space and we don't know what's going to happen in May?
Cruises. I think the world's best Petri plate. I think it's one of those things when definitely when we think about places I would wear a mask, the long time that you spend in a cruise ship, the tight quarters and everything else like that, that would be the one ideal place that I think kind of makes me want to wear a mask and be careful about it. Vaccines will take about 2 to 3 to 4 weeks to kind of see a response with that. So ideally doing the booster kind of right ahead of that. And then as far as my views on things, I think my biggest concern is level of disability and kind of other things associated with that. I'm particularly worried about patients who are non-mobile as far as risks of kind of bad outcomes with COVID. I think the other things you have to kind of look a little bit and kind of see how many of the other ones you have. But I think we've seen a lot of people with the other ones do really well, especially if you're vaccinated, boosted, Evusheld, having, treatments available. Part of the question might be is, are you, the cruise ships probably will have something like remdesivir or Paxlovid available in the pharmacy, but that might be a great question to ask. Should you get it? Are you going to be prepared for it? And those kinds of things.
And a related question, which I forgot to ask: when should they, with the assumption that we know about vaccines now, when should they get the vaccine before the cruise? If
Yeah,
ever?
yeah. So getting the vaccines, because it takes about 3-4 weeks to kind of get that full response to the vaccine. Trying to do that 3-4 weeks before you head on the cruise might be a good time to do that, or at least a little bit before that as well. Uh, but the closer you're getting, the tougher it's going to be to kind of mount up a good immune response.
All right, there are a couple of questions related to DISCO. Obviously, I didn't give the entire discussion about the DISCO MS study. One question was, what did we actually study? So we studied whether or not, if you did a randomized controlled trial of people 55 and older who had been stable with no relapse for 5 years and no scan change for 3 years, half the people randomized to stay on drug, half to go off drug. We measured relapses, new scan changes, progression of disability on examination, where we use the EDSS, Expanded Disability Status Scale. We also studied quality of life measures, a number, about 20 different quality of life measures. How did the patient feel about how they were doing, as well as safety. And I didn't mention the quality of life study component of it. We looked at symptoms and a variety of other things. There were no differences between people on and off drug at the beginning or at the end of the study. There was no increased risk nor decreased risk, maybe a slight decreased risk of adverse events in the people who went off drug, but generally the number of people with adverse events and the number of people with serious adverse events was pretty much the same in both groups. But the main outcome was that relapses and progression of disability were roughly the same between the two groups, but probably a slight increased risk of having new MRI activity, the significance of which is not clear. And for a specific question related to what you would do with this information, someone asked the question, well, I'm 7 years old, I've been stable for 17 years. Can I discontinue or taper off my medications? And of course, I don't know everything about all your details, so I can't give you a perfect answer. But that's the target audience for this study. And I think it's going to be individualized for each person. But if you have truly been stable with no relapse, no scan change for 17 years, and you are 70 years of age, and were presumably diagnosed at least 17 years ago, if not many years before that, the likelihood that you would do well going off medication is extremely high. This is the DISCO study, but I personally have probably taken 200 people off drug outside the study, and the vast majority have done well. Is there still retained risk? Absolutely. Have we had people in their 70s have a relapse? Yes, we have. Have we had people had active scans in their 70s? Yes, we have. But they're very uncommon. And then you have to weigh the risks of the medication and everything else that goes with that, costs and other things, and say, is that a risk that is reasonable for me when that risk is very low and the potential benefits are perhaps also very low of the medication? Then that is potentially a time that you would want to consider going off the medication. And it's a trial. If you have new disease activity, you can go back on. So there's nothing lost from going off in the vast majority of people. This is a very broad question for Dr. Shah, but I think it gets at sort of our general view of how we treat people in a big picture sense. And that is, how do you remain healthy overall? We talk a lot about disease modifying therapies, but tell us the bigger picture of how we retain health and about wellness.
So that's a little bit of a loaded question, but what I might say is that things that we associate with good health overall are going to be things that are associated with good health in MS. So we've touched about this in a variety of ways throughout the presentations this morning, but eating well. And so I think one of the other questions that maybe I'll just hit, just because we're on that topic, there's all this thought about diets in MS, and is one specific diet more important in MS than others? And what we know about that is things that are good and healthy for overall brain health are going to be the things that are good and healthy for patients with MS. So you hear us talk about the Mediterranean diet if we had to choose a diet, but I mean, kind of eating with common sense and not eating chocolate cake for dinner, for example. Now, that's an extreme example, but still an example nonetheless. So eating well is going to be important, making sure that you're staying physically active. And of course, physical activity can look different from person to person. So it doesn't mean, gosh, I need to be in the gym 30 to 60 minutes a day, every day of the week, but really pushing yourself in small incremental ways that can actually make a sustainable difference over the course of a year is going to be important. Healthy habits otherwise, so staying physically and socially engaged, making sure you have a support network to lean on. And then, of course, if things come up, making sure you've got a good relationship with your doctor is important. Staying regular with regular visits with primary care is also going to be important. We know there's an increased accumulation of disability in individuals in MS that have poorly controlled diseases outside of MS, like blood pressure, diabetes, cholesterol, things like that. So staying up to date with your primary care doctor is also incredibly important.
All right. We've made it all the way through today without talking about BTK inhibitors. So, BTK inhibitors represent a new potential class of medications that share some similarities with the B cell depleting therapies, except there's no depletion. It's really more of turning down the volume, if you will, but also offer the possibility of potentially treating progressive MS as well as relapsing MS. And Dr. Alvarez is in charge of either all of them or nearly all of them at our place. And there are a bunch of them. So if you could just tell us a little bit about BTK inhibitors, what their role may be, because none of them are available yet, and what your sort of view is as to where they might place themselves. Tell us a little bit about.
Yeah, so summarize BTK information. All right, so tyrosine.
There you go.
Try that again. All right, perfect. So BTK inhibitors, a little bit of an overview. So Bruton tyrosine kinase is the enzyme that activates B cells. So if you are trying to fight infection, that's a good thing. You want that. If you're if it's attacking your brain, then it's a bad thing, and you try and inhibit that. The nice thing about it is, unlike B cell depleters, where it might take months to a year plus for those B cells to come back, that process can be reversed within usually a few days to a week or two, because all you have to do is make that protein back. It's a tyrosine kinase, and we make hundreds of different tyrosine kinases. And so, how specific it inhibits the Bruton type of the tyrosine kinases is kind of the differences that we see between all these different drugs. And there's a lot of different BTKs that are coming up, including some that are already on the market. Predominantly, they've been used in the cancer world. So B cells can become cancerous. And so they've been added in for those kinds of cancers now for a number of years. Those are dirtier BTK inhibitors because they can hit a lot more of those different tyrosine kinases. And if you hit some of the other ones, you can end up with some potential side effects related to whatever other tyrosine kinase it's hitting. And the biggest concern that we had with this was related to blood clots and bleeds. The generation of BTKs coming in with MS are much cleaner, so they only predominantly would hit the Bruton tyrosine kinase. They tend to hit 2 or 3 other ones as well, but it tend not hit like 20 of them like the older ones used to. So they tend to be cleaner, more specific. The bleeding issues don't seem to be much of an issue related to the MS drugs. The benefits is that it's a small molecule beyond sort of what we were talking about, how fast you can reverse it. And so the idea is they could make it into the brain. So the B cell depleting, the big antibodies don't make it into brain very well. So if you have bad B cells in the brain, those are going to live until those B cells die on their own or find other things happening to them. And they also have potentially some effects on other immune cells like microglia that are part of the immune system in the brain that might play a role in progressive forms of MS. So there's a lot of excitement about having an effect on progressive MS as well, beyond sort of the relapsing studies. I won't get into a lot of the detail for their clinical trial data because it's a little bit all over the place. Two of the drugs have presented data on phase two, kind of smaller studies. They look as good as at least the middle tier, the oral drugs, and might be as good as the high tier, the infusions. So somewhere in there might be helpful. There's not been anything as far as progression, but those are some of the studies that we're looking at. From a safety perspective, the other thing I would mention is one of the drugs, it's halted now in the US. Tolebrutinib was put on hold because of liver issues. There were 4 cases of liver damage that reversed on their own, but they wanted to kind of put in some safety checks. So those studies are recruiting in the Western world, but not in the US. And they'll probably get restarted back in November. As far as when they may come out, the first study that was the big phase 3 trials for approval was done recruiting because of the Ukraine war. It had to start recruiting again because a lot of the patients are unfortunately neither Russia or the Ukraine. And so it was hard to do the evaluations and things like this with a lot of people having to leave the Ukraine, dying or other things like that. And so they've opened it up back up, probably be closing fairly soon. Again, Tolebrutinib just finished, the one that was halted, finished their phase 3 trial recruitment about 3-4 weeks ago. So that kind of marks when we might start to hear data. So these are studies that will probably go for at least another 1.5 to 2 years. And then there'll probably be another 6 months for data analysis and meetings to occur and things like that. So I would probably start expecting data in about 2 years for the relapsing studies, and the progressive ones are all still actively recruiting. There are several of these. There's Evobrutinib, which was kind of the first one to come out. Tolebrutinib is the one that was halted. That's kind of has its phase 3 trial done recruiting. Fenebrutinib is the kind of the third one that's in line as far as these studies go. Those last 2 are the ones that have progressive trials. So we'll hear about that. And then Novartis also has Remibrutinib as a 4th one, and Biogen has one as well that are looking at it. TG is evaluating. They have a BTK inhibitor. So there's potentially 5, 6, 7 of these that are getting potentially going through the pipeline to get evaluated. So that tells you a little bit about how excited the field might be about these things and how people see them. So it's kind of an exciting time for those. But again, probably looking at 3-4 years before we hear more.
So that's a segue for, I talk about discontinuation medicines as people get older, in part because they may be stable, also in part because they may not be as effective in, say, progressive MS patients. We're hopeful that the BTK drugs will be helpful. Other approaches are also potentially beneficial. So 1 or 2 people asked the question, well, if I have progressive MS and the medicines that are presently available are not very useful, do we really just focus only on quality of life? And so a couple of things about that. 1, we focus on quality of life from day 1. Quality of life is important from day 1, as Dr. Shah was discussing. And we think that does make a very important distinction throughout the career that someone has with MS. Focusing on comorbidities is extremely important. They have not only delay the diagnosis of MS when people are younger, but have a bigger impact as people age with diabetes, high blood pressure, elevated lipids, vascular risk factors, all of which play a big role. So it's not just quality of life. Quality of life is very important. But other approaches which are potentially quite useful beyond the BTK inhibitors are things that don't necessarily adjust or alter or suppress the immune system, but remyelination strategies, regeneration strategies, and neuroprotective strategies. It says 8 minutes here, not 5. And so there are a number of ongoing studies that are looking at really alternative ways of thinking about it. Because you can think that you'd like to try to prevent MS. You'd like to try to treat it with immunotherapy, which we do. You might want to treat symptoms. You might want to treat relapses. But you also might want to regenerate nerves, remyelinate nerves, and protect nerves from dying if they were injured 3 years before or 10 years before. And there's a process that starts that will ultimately result in them dying because of damage to energy production and other things in cells. What can we do for all of those things along the way? And there are studies looking at all of those things now. None of them, unfortunately, really ready for prime time yet. One specific one that was looked at recently was Biogen. Unfortunately, failed in a second very large, well-done study. Also looking at alpha lipoic acid, we will not have alpha lipoic acid data for probably at least another 6 to 12 months, I don't think. But other agents as well. So no one has forgotten about progressive MS patients. It is just a much more difficult problem because the basic underlying pathophysiology is not as well understood, and the approaches are much more difficult to get at them. I'd like to ask Dr. Shah to answer a question. One person asked, well, hey, I'm JC virus positive, so I don't really have any choices for my MS, suggesting that perhaps there's a risk for everybody if they're JC virus positive. But who really has a substantial risk, and when does being JC virus positive change our view of what medicines we can use?
So for those of you that aren't familiar, JC virus is also known as the John Cunningham virus. We worry about it in particular settings because it increases the risk of someone developing a brain infection called progressive multifocal leukoencephalopathy, or PML, which is why we say PML, because it's easier to say. But that being said, so Tysabri or natalizumab, which is that infusion that's done about every 4 to 6 weeks, is the medication that we see that has the strongest association with PML risk. And I think Dr. Schreiner touched on that briefly in terms of what that risk is in her presentation. Now, the rest of the medications that we use for MS, I think particularly when we think about things that are on that immunosuppressive type angle, I think it's probably not okay to say, hey, this medication will never, ever increase someone's risk of MS, because I think as we begin to mess with the immune system, there is a risk of PML with all medications, even if they haven't been reported quite yet. But I think the most important thing to think about is how many cases of PML have we actually had on certain medications in individuals that are JC virus positive. So in terms of cases that have been reported thus far, there have been the most cases reported associated with natalizumab. The second group, that's probably the highest reported cases, which might have something to do with how long the medication has been out, has been Gilenya or fingolimod. The third most common medication associated with this, and all of these are way less than natalizumab, is dimethyl fumarate or Tecfidera. There have been 2 cases reported with ocrelizumab that were thought to be true cases of PML associated with that medication and not carryover from another medication. And so I think we say they all have some risk, but it's really looking at what is that risk compared to what our denominator is, or how many patients have been on this medication, and then really thinking about that small risk in some cases compared to the very real risk of what happens if we don't treat MS effectively, which we know a lot about because we didn't have treatments for so long.
And for Dr. Alvarez, we use a lot of the so-called B-cell depletion therapies or CD20 agents in our practice, but also around the world that's true as well. And one of the substantial risks associated with that is infection with long-term use. And could you please comment on the relationship of the use of these agents, duration of use, dropping of immunoglobulins, hypogammaglobulinemia? We need something for that, euphemism for that one. And how we might manage and how we might think about altering our use of either the CD20 agents or adding other things to it, like IVIG. For many people, now we've had people on these agents for 10 or 15 years.
So I can cover that topic in about an hour. So no problems there. So kind of just big picture type thing. So when we look at our B-cell depleting therapy use, it is probably at least 80%, probably closer to 95% of what our patients would start off these days. And what drugs we start people on changes depending on what drugs are out and things like this. But part of the reason we've liked them, especially very early on, has been because we don't see a lot of risks early from an infection perspective. We also see that the biggest benefit from these drugs occurs when we use them early. And the younger you are, the more active the immune system is. And so our kind of risk benefit of these drugs, and Dr. Corboy showed some of the graphs that we've showed in the past and some of the data that we have, is that that difference between sort of middle tier drugs and high efficacy tiers drugs is the biggest early on. And then the risks at the end become these risks associated mostly with disability. We see them associated with age and other things like that as well. And so trying to stop treatment, de-escalate treatment later, the idea of we're going to save this drug to later, the only thing it's saving it for is when it doesn't work and it just looks like any other drug, or when it has more risk associated with that. And so that's been kind of a thing that Dr. Volmer and Dr. Corboy from the get-go at this center have really pushed this idea of high efficacy therapies early for us. The risk of hypogammaglobulinemia is not big. It's probably a couple of percentage points by year 2 or 3. And the hard part is knowing where, how low is low and how low can you go, kind of a thing with them. And kind of what the options are. Most patients can be on these drugs, and we've had patients on these drugs for 10, 15 years. And with 10 or 15 years, we've only had to start antibody replenishment with IVIG in a couple of times. I think the question is as we identify this and we start to look at these levels, is trying to prevent that from getting to a point where it's a concern. And so if we can change people out by monitoring those levels before it becomes a problem, then we can prevent that and not have to go to IVIG as much. And that's kind of the part that we've been looking at a little bit to try and understand those risks better.
Fair enough. It just hit 0. So I think we're good. Thank you very much for coming, everybody in person, online, and who's ever listening to this 5 weeks from now. We appreciate you coming, giving us part of your beautiful day. Go out and enjoy the colors on the trees. They're fantastic. And enjoy the rest of your day. Thank you very much.